Additionally, there's a question in my mind, do they have a history of other issues that might require lower pressures for longer periods of time before I'll feel safe about going to higher pressures that might be their target pressure? An example of this might be a patient with Crohn's and colitis who also has a long-standing history of brain trauma. The Crohn's and colitis, which they might be coming to the office for, I could treat at 1.75, 2.0, 2.2, 2.4. In many ways, while even lower pressures will reduce the inflammation of the autoimmunity typically, healing the intestinal lining is a lot like wound care. And so 2 to 2.4 is very realistic for a lot of those patients. However, this long-standing history of brain trauma, which I would typically treat between 1.3 and 1.5, is much more delicate tissue. We know that the brain requires a tremendous amount of oxygen and is some of the most sensitive tissue to hyperoxygenation, potentially leading to consequences like central nervous system oxygen toxicity. So I don't want to push their brain any faster than we need to in order to get to the higher pressures, which may be required for the healing of the intestinal lining. So in a case where there's two different issues that they're having, even if their priority was one at higher pressure, I feel a need to treat that more sensitive tissue for a period of time before moving up towards their target pressure.